Hello. Rajeshwari, you have joined?
Ma'am, my name is Neha Pandit. I'm from Emcure.
You are from Emcure?
Yes, ma'am.
So you play all the CVs?
Yes, ma'am. I will help in that.
Okay. Yeah. Thank you.
Yeah.
Start.
Should I share, ma'am?
Yes, you can share your screen.
Yeah. Is it visible?
Yeah.
Okay.
Patient complaint or preferential liability.
Okay, on behalf of ISAR MP chapter, I, Dr. Pratishtha Dalmia, welcome you all for a much-awaited webinar on endometriosis. March has been an endometriosis awareness month in which various endometriosis awareness programs, camps, CMEs, webinars, marches, training, etc. has been done by various gynec societies all over India. It's our pleasure that our chairperson endometriosis committee, FOXY, Dr. Asha Rao is with us today as guest speaker, along with two other speakers, Dr. Vrinda Joshi Kale and Dr. Dhaval Bakshi. So I welcome our patron, Dr. Dheeraj Gada sir and Dr. Asha Bakshi. I do the floral welcome. Dr. Asha Bakshi is the founder chairperson of MP chapter ISAR. I also do the floral welcome of Dr. Randhir Singh, who is an immediate past chairperson, MP chapter. Please change the slide, please. Neha. Yeah, I welcome Dr. Dheeraj Gada sir, who is a patron of and past president ISAR, Dr. Asha Bakshi, founder chairperson, MP ISAR chapter, and Dr. Randhir Singh, who is an immediate past chairperson, MP ISAR. I also do the floral next slide, please.
Yes.
I do the floral welcome of Dr. Vrinda Joshi Kale, Dr. Asha Rao, and Dr. Dhaval Bakshi, who are the today's speakers, and Dr. Archana Baser and Dr. Rosa Oliai, who are the chairpersons of the today's meeting. I also do the floral welcome of Dr. Shashibala Bhosle, who is the president GOGS, and Dr. Preeti Gupta, who is the secretary of GOGS, and Dr. Yateen Singh Verma, who is the chairperson of the MP chapter ISAR, and is the director of Verma Hospital and Infertility Center, Gwalior. Now I invite you for the digital lamp lighting. Please play the digital lamp lightning. Thank you. Now, I invite Dr. Yateen Singh Verma, who is the chairperson, MP ISAR chapter, and is the director and embryologist at Dr. Verma Hospital and Fertility Center, Gwalior. He is the past chapter, MP chapter IFS secretary, and he has several healthcare awards in his credit. I invite him for the welcome address.
गुड इवनिंग ऑल दी फ्रेंड्स, आप सभी को नव संवत्सर और गुड़ी पड़वा की हार्दिक शुभकामनाएं. As you all know that MP chapter ISAR was installed in 2011, and at that time Dr. Dheeraj Gada sir was president Central ISAR, and Dr. Asha Bakshi madam is the founder chairperson of MP chapter ISAR. So Dr. Gada sir and Dr. Asha Bakshi madam is the most important pillar of our chapter. I think that Dr. Gada sir is due to some health issues unable to join today. So I, Dr. Y.S. Verma, chairperson MP ISAR, Asha Bakshi madam, And it is my proud privilege to introduce our founder chairperson at present. She is Treasurer, Central ISAR and Vice President, Boxy West Zone. And she is Chief Consultant at Disha IVF Center associated with the Motherhood Child Hospital, Indore. Thanks, madam, for joining as an expert here. And I welcome our dynamic GOGS President, Dr. Shashibala Sahu, madam. And very active Secretary GOGS, Dr. Preeti Gupta, for being the part of webinar of very important topic of endometriosis. I welcome all the today's speaker, Dr. Branda Joshi, Dr. Asha Rao, madam, and Dr. Dhaval Bakshi for speaking on the topic and sparing time for joining here to deliver their talk on this important topic. And I also welcome our today's program chairpersons, Dr. Archana Basir madam and Dr. Rosa Oliai. And I welcome all the MP chapter ISAR members, delegates, and other participants who have joined here, and GOGS members also. Please go ahead.
I just want to share my screen.
Hello.
Manish,
Yes, ma'am.
I am sharing my screen. मेरा screen है ना, share कर दो. Yeah. ये पे चले जाओ, फिर आओ वापस. इसको कैसे करेंगे? वो उनको बंद करना पड़ेगा शायद. यहाँ से हो जाएगा. हेलो नेहा, प्लीज स्टॉप योर स्क्रीन. हो गया? शेयर हो गया? हाँ, नहीं आया. Actually, just want to show a video, so just I want to show share my screen. हो रहा है? लाइव करो, नहीं तो अपना आना चाहिए ना शेयर फोल्डर से.
अभी आया नहीं है दीदी.
हाँ, आया नहीं ना.
नो,
अपना वो दिखना चाहिए ना हमारी स्क्रीन.
नहीं तो तुम्हारा शेयर स्क्रीन का ऑप्शन देखो नीचे. पहले तुम्हारे प्रेजेंटेशन को मिनिमाइज कर लो और फिर शेयर स्क्रीन का ऑप्शन देखो नीचे.
अपना वो फोल्डर कहाँ खुला है?
उसको मिनिमाइज कर दो पहले.
ओके, ओ यस यस, ठीक है, चलो ठीक है. वीडियो खोलो, वो शेयर फोल्डर से बस मेरा वाला खोल दो. शेयर फोल्डर में था ना. यू आर ऑन पीपीटी. फर्स्ट स्लाइड शो. You can see?
yes.
Yeah. So, as the topic of today's webinar is fertility issues in endometriosis, and endometriosis is March month is the endometriosis awareness month. So that's why we are focusing on this chronic debilitating disease. Endometriosis and adenomyosis roughly affects about 10% of the reproductive women all around the world. It is a chronic disease associated with so many problems in a woman's life, from severe pain during menses to pain during sexual intercourse and various fertility issues. This webinar is covering all the topics: early diagnosis, management, medically as well as surgical endometriosis and adenomyosis management. I want to show you a video which shows what is the agony patients facing in endometriosis. Just keep the patient. This is the endometriosis song.
No audio. ऑडियो नहीं है ना?
ऑडियो
It's
नहीं आ
not
रही?
audible, Didi. It's not
Okay.
audible.
मैम जब आप शेयर स्क्रीन करोगे तब आपको शेयर साउंड उधर नीचे लेफ्ट हैंड साइड में दिखेगा, उधर करिए क्लिक। जब आप स्क्रीन शेयर करते हो ना तब आप उधर लेफ्ट हैंड साइड में आएगा शेयर
अच्छा,
साउंड।
कहाँ पर?
एक बार स्टॉप शेयरिंग करिए।
स्टॉप शेयर करो।
हाँ, अभी फिर से आप स्क्रीन शेयर करोगे तब
हाँ
आपको
ठीक, कहाँ?
लेफ्ट हैंड साइड में दिखेगा नीचे शेयर
हाँ,
साउंड। साउंड पे
शेयर
क्लिक
साउंड
करिए।
ये कर दो, ठीक कर दो।
हाँ हाँ, और
हाँ।
फिर बाद में शेयर करिए। हाँ
ठीक ठीक, अब शेयर करो।
ओके,
शुरू से लगा। हाँ, करो।
यस नाउ ऑडिबल।
Now audible? Okay.
Yeah.
They say you look fine to me, but I don't have strength to get far. I'm buried beneath this pain. I'm covered in all these battle scars. My body's bruised and I'm broken. Doesn't anybody notice I'm barely hanging on? Taking pills and potions, I'm self-diagnosing. Something must be wrong. Beyond invincible, warriors bleed. Let me be strong enough to fight everything. I can be strong and superwoman, but still human underneath. We aren't invincible. Warriors bleed. Warriors bleed. It's time to start a family, a little one, maybe 2 or 3. I think I could be a great mom. Wouldn't it be a dream? Can't wait to feel you kicking me. But I never thought that you'd be gone. My body's bruised and I'm broken. Doesn't anybody notice I'm barely hanging on? Taking pills and these potions, I'm self-diagnosing. Something must be wrong. We aren't invincible. Warriors bleed. Let me be strong enough to fight everything. I can be strong and superwoman, but still human underneath. We aren't invincible. Warriors bleed. Warriors bleed.
Stop कर दे। So this video showing, hello, I'm audible? Yeah, this video showing a woman having endometriosis in so many pain and agony. That's why we all are here together for discussing all the things. It's my pleasure to introduce today's speaker. Our first speaker, Dr. Vandha Joshi. She is head of the department, GR Medical College, OPG by department. She is my teacher also. And she done graduation and post-graduation from Jivaji University, Gwalior. And she had international fellowship of ICOG in 2006. She is medical teacher for last 26 years, having so many awards, publication, gold medal, and so many associated membership. Our next speaker is Dr. Asha Rao. She is Director, Rao Hospital and Care, Coimbatore. She is Director for Postdoctoral Fellowship Program in Reproductive Medicine and Endogynecology. She is a chairperson Foxy Endometriosis Committee, and she having so many publication research and special achievements. Dr. Dhabal Bakshi is a laparoscopic surgeon, laparoscopic, hysteroscopic, endoscopic surgeon in Indore, and she is a fertility specialist and endoscopic specialist in Disha Fertility and Motherhood Hospital, Indore. She is trained in advanced endoscopic surgery also. She had gold medal in MCH reproductive medicine and surgery, and he had champion of ISAR award in 2020. So welcome all our guest speaker. Now I hand over the mic to our MOC Pratishtha Dalmia to introduce our chairperson. Please,
Thank you, Dr. Anju. Let me introduce the chairpersons to the audience. Our first chairperson is Dr. Archana Baser. She is a vice chairperson, MP chapter ISAR, and chairperson elect MP chapter ISAR. Dr. Rosa Oliai, she is an MS, FICOG, and FICMCH. She is the director of the Oliai Hospital and Research Center, Gwalior. She is the board of member of committee Family Planning Association
please,
of India, FPAI.
Put the CV. Neha, please put the CV on.
Yeah, ma'am.
Dr. Rosa Oliai CV, Neha.
Which doctor?
Yes. Niche. No.
Aage,
Next. Yes.
Yeah, this one.
Okay.
She is the Dr. Rosa Oliai is the board of membership committee Family Planning Association of India, FPAI. She was the vice president of Foxy 2014, the chairperson Adolescent Health Committee Foxy 2012, a WHO consultant with expert panel meet for making global guidelines on adolescent sexual reproductive health, Geneva 2010 to 11. She was awarded prestigious Dr. DC Datta Prize and awarded prestigious Mehru Dara Hansotia Prize for various activities, and she has also authored and co-authored several books in obs and gynae. I welcome both the chairpersons to today's webinar. Now, I invite our first speaker, Dr. Vrinda Joshi Kale, for her topic on evaluation and medical management of endometriosis. Welcome, Joshi ma'am. Dr. Vrinda Joshi, ma'am, for her first speaker on her topic.
I think he join, but he is joined. आपके द्वारा डायल किया गया नंबर. Neha, can help too?
Do you want me to go ahead? If you have problems, I'm not in a hurry.
No. Just 1 minute, I want to connect you. हेलो, हाँ दीदी आप कनेक्ट करिए, आप स्क्रीन शेयर. हाँ हाँ
और ये है ना डॉक्टर मेरे वो बोल रहे थे उनका ठीक है।
अच्छा, नहीं तो फिर अभी डॉक्टर आशा हमारे फिर पहले लेक्चर ले रही है, जब तक फिर सेकंड ले लेना, ठीक है? हाँ हाँ ठीक। हाँ मैम, यू कैन स्टार्ट मैम।
Shall I start?
या यू कैन स्टार्ट दीदी, फिर लेक्चर हो जाएगा, फिर डॉक्टर आशा राय बोल रही है।
Yeah, I'll just share the screen.
हाँ, जब तक 15 मिनट मिल जाएंगे। हाँ ठीक ठीक, हाँ ठीक, हाँ
Yeah. So thank you so much, dear Anju and the team, for this opportunity, and very happy to see so many of my friends, starting from Asha Bakshi, Pratishta Dalmia, and Pam Sao. So lovely meeting all of you here on this day of Gudi Padwa. I bring you greetings from Coimbatore and from the Foxy Endometriosis Committee. In fact, this is my 4th year. I got as a bonus 3+1. इंडिया में तीन बरस करेंगे तो 1 बरस बोनस मिलता है. So this is the 4th year of mine. Are you able to hear me? Hello?
Yes, ma'am. Yes.
या
Carry on, ma'am.
Yeah. So this is my 4th year as the chairperson of Endometriosis Committee. And March is the month for endometriosis awareness. And we have been conducting so many programs. And we saw such beautiful programs from Pratishta Dalmia and her team. And many of my colleagues regarding awareness on endometriosis. And I thank the MP ISAR committee for having given me this invite to speak on adenomyosis and its impact on fertility. Adenomyosis is very close to my heart. I'm very passionate about adenomyosis because as the incidence of endometriosis is rising, so is the incidence of adenomyosis. And it's very sad to see these women suffering from so much of pain, dysmenorrhea, menorrhagia, recurrent pregnancy loss, recurrent implantation failure. And those days, the disease was diagnosed historically by histopathology at hysterectomy. But today, more and more, we are seeing it in younger women and infertile women. This change in trend is quite frightening. Perhaps because we are shifted of fertile years from 20s to early 40s, and also because of better diagnosis. Today, we have the non-invasive methods of diagnosis, that is by imaging. So both together, postponing fertility and better diagnosis, we are seeing so much rise in the incidence of adenomyosis, and we are seeing it in 30% of young women and infertile women, and diagnosing 20% of infertile women less than 40 years undergoing ART. That means unlike those days where surgery was offered as a mainstay of management for adenomyosis, we cannot offer this anymore because they are young women. We have to preserve their uterus. We have to preserve the integrity of the uterus, because right from 1952, I can see that a lot of surgical procedures have come in to help women with adenomyosis. But if you see in the last 15 to 16 years, ever since JNRH analogs came in, we are seeing a strong change in trend. From surgical therapy, it is going more and more towards the medical therapy. My journey into adenomyosis started in 1992, I would say, when a young woman who was married for 16 years, yet she was only 34 years. She came to me with severe dysmenorrhea and infertility, and she had an enlarged uterus of about 12 weeks. And on laparoscopy, she had a bilateral cornal block, no spill. Tubes looked apparently healthy, but there was no spill. So it was a case of cornal block. And 1992, all that we could offer was danazol. We gave her danazol for about 4 to 5 months. When we stopped it, she promptly conceived. And the daughter that was born in 1993, she got married last year. And it was such a beautiful occasion. And adenomyosis is the benign invasion of endometrium into myometrium, producing diffuse enlargement of the uterus with hypertrophy and hyperplastic myometrium. It can be focal, as you see here, small focal, large focal, and diffuse adenomyosis. And it causes severe dysmenorrhea and menorrhagia in about 50% of patients. It can also cause chronic pelvic pain. It can be asymptomatic in 20%. And today, the reproductive dysfunction in the form of infertility or recurrent implantation failure or recurrent pregnancy loss are also taken as the implications of adenomyosis. So considering that 20% of patients can be asymptomatic and others can have some minimal symptoms, it's very important to think of adenomyosis and screen women for adenomyosis in your infertility clinics. So screen for adenomyosis, hunt for adenomyosis, because I would say that many of the reproductive outcomes, which are said to be the adverse outcomes of endometriosis, are actually because of adenomyosis, which was not diagnosed those days. Today, in the last 5 years, I'm taking an incidence of the reproductive outcomes in endometriosis. If there is no adenomyosis, the reproductive results are as good as any other woman. Only when it's associated with adenomyosis, there is a problem with the reproductive outcomes. So it is very important to screen your patients for adenomyosis because it causes altered contractility of the myometrium, leading to impaired gamete transport and infertility, poor implantation, poor placentation, leading to miscarriage, preterm labor, IUGR. And there has been a beautiful paper by Toga Sulandi et al. In Fertility Sterility, which concluded that in the IVF scenario, they saw lower rates of successful implantation and increased risk of pregnancy loss, translating into overall significant reduction in live birth rate. So whenever you do a good IVF, see that your patients are treated for adenomyosis before you do a embryo transfer, so that you avoid this adverse outcomes in these patients. The true incidence is difficult to find out because we do not have histopathology results in most of our patients. 21% of women with endometriosis concomitantly had adenomyosis. 28% of subfertile population has adenomyosis alone. And 54% of young women with infertility and dysmenorrhea and menorrhagia could also be having adenomyosis. And this is a beautiful picture of the junctional zone. You can see here the myometrium, the endometrium, and this thin halo that you see is the junctional zone. It is a subendometrial myometrium, which is barely visible. It is not more than 4 to 5 millimeters in normal women. And whenever it is more than 8 millimeters, you can suspect adenomyosis. And if it is more than 10 to 12 millimeters, you can diagnose adenomyosis. And earlier, MRI was considered the best for diagnosis of adenomyosis. You can see the junctional zone beautifully by MRI. This is the endometrium. This is the junctional zone, the dark area, and this is the myometrium. So diffuse local widening of the junctional zone wider than 12 millimeters, myometrial mass, and small hypointense myometrial spots and uterine enlargement. These are the criteria by MRI. And you can also classify the disease into number 1, simple junctional zone hyperplasia, partial or diffuse adenomyosis, and adenomyoma. Adenomyoma is a cystic lesion in the posterior wall that also is a feature of adenomyosis. But today, more and more, we can diagnose adenomyosis with ultrasound with almost 80 to 90% accuracy. And these are the criteria by 2D ultrasound: globular asymmetric uterus, irregular cystic spaces, myometrial linear striations, which you can compare to the rainforest appearance of Australia, poor definition of endomyometrial junctional zone, heterogeneous myometrial area, myometrial anterior and posterior asymmetry, which is very important, thickening and or increase in the echogenicity. And this is how you diagnose adenomyosis with 2D ultrasound. But my dear friends, it's rather late when you diagnose like this. So kindly learn, most of us have a machine with us. So buy a machine where you can do a 3D. And you look at the vascularity. In case of fibroid, it is a peripheral vascularity, whereas in case of adenomyosis, it is the vascularity into the myometrium. This is one feature. And the lesion is not well demarcated like a myoma. This is adenomyosis actually. And you learn to do power Doppler and 3D. With 3D, you can see this is the endometrium, myometrium, the dark area is a junctional zone, and this is a small focal adenomyosis, early infiltration of junctional zone by adenomyosis. This is once again focal adenomyosis, which could be about 2 centimeters. So learn to diagnose adenomyosis in this stage and not like this with big adenomyosis uteri, where it is too late to do anything. If you diagnose it early, you can suppress it early and you can have very good results for ART and less of recurrent pregnancy loss. This is a cystic lesion in the posterior myometrium, which is the adenomyoma. So what is the pathogenesis? What happens with adenomyosis to fertility? There basically seems to be a local hyperestrogenism leading to increased peristalsis, tissue injury and repair. And that leads to thickening of the junctional zone. Here again, you can see the endometrium, the junctional zone, which is a thin line here, and the myometrium, which is thickened. So there are changes in the endometrium, thickening of the junctional zone, and myohyperplasia. And in the endometrium, we can say there are lots of changes at the molecular level. The factors which are favorable to implantation are decreased, like FOXO1A, HOXA10 mRNA, integrin, interleukin 10, L-selectin ligand. These factors are decreased, and factors which are adverse to implantation are increased, like beta-catenin, CD68, interleukin 6, macrophages, natural killer cells. So factors which are adverse to implantation are increased in the endometrium. So there are changes in the endometrium also. And there is a thickening of the junctional zone, which increases the peristalsis. And there is a myohyperplasia. All these together leading to infertility and reproductive dysfunction. And in fact, during ovulation, we can say that the junctional zone is very important for the uterine peristalsis in the subendometrial area. It causes peristalsis and transport of the gametes towards the fundus, the sperm from cervix to fundus, and the ova from fimbria to fundus, promoting fertilization and implantation. Because after ovulation, the peristalsis quietens down. Whereas if there is a adenomyosis and thickening of the junctional zone or myohyperplasia, you can have excessive contractions, which can interfere with fertility and also cause early pregnancy loss and also mid-trimestral loss. So it's very important to diagnose adenomyosis in your infertile patients. According to Pivers et al., the junctional zone thickness is the best negative predictive factor for implantation. If the junctional zone is less than 10 millimeter, the pregnancy rates in IVF could be more than 45%. If the junctional zone thickness is more than this, the pregnancy rates drop down to almost 16% and as low as 5%. So once again, screen for adenomyosis and suppress it prior to embryo transfer. And this is the myohyperplasia. You can see this is a normal junctional zone. This is some form of adenomyosis, and this is severe adenomyosis causing total destruction of the endometrial cavity. So this localized expansion of the junctional zone and massive myometrial hyperplasia and fibrosis changes the plasticity and tonus of the uterus and changes the contour of the endometrial cavity, once again leading to the various problems that you see in adenomyosis, like poor implantation, poor placentation, placental malposition, preeclampsia, small for gestational infant, miscarriage, etc. And all this happens because of the chronic inflammation, which also leads to impaired uteroplacental perfusion. And this is a fantastic paper by Hashimoto et al. Fertility in adenomyosis decrease. You can have a pregnancy loss of about 32% in women with adenomyosis compared to 14% in women without adenomyosis. This is a paper by Verslini et al. And there are another 7 papers from 2006, Joang et al., Machimoro, Hashimoto, Tamura, Shin, Yamaguchi, Razavi. I have read their names so many times, so I feel they are my friends. So from 2006 to today, over 16 years, there are so many papers which talk about the reproductive problems that are caused by adenomyosis and how do you treat them when they come to your doorstep seeking fertility. It depends on the age, desire for fertility, diffuse or focal, and other associated factors. And there are no proper guidelines. Endometriosis, at least there are good guidelines by the various societies, but for adenomyosis, yet we do not have proper data. When to suppress adenomyosis, what size you have to do surgery, at what size of adenomyosis you have to do suppression, how long you have to do suppression. There are no proper data, but generally it was treated by surgery earlier, later by medical management, now in the last 10 years, and along with ART as and when required. And medical management, NSAID help basically for pain relief and OCP also in women who do not require fertility. Danazol lost popularity because of the severe androgenic side effects. So today our dear friend is GnRH analog in the infertility clinics, along with Dinoges, aromatase inhibitors, ART, And sometimes we use the intrauterine system with progestogen. Uterine artery embolization and HIFU are under trial. So in the setting of infertility, GnRH is the best medication, I would say, because if you use it for 3 to 6 cycles pre-embryo transfer, it optimizes the pregnancy rates. It reduces the expression of aromatase cytochrome P450, the utopic endometrium of women with adenomyosis and endometriosis, decreases the expression of nitric oxide synthetase. Of course, you also always have to give a progesterone add-back therapy to reduce the loss of bone mineral density. And according to Niu et al., a long course of downregulation significantly improved the clinical pregnancy rate, ongoing pregnancy rate, and implantation rate in patients with adenomyosis. After 2 to 6 months of GnRH analog, a mean uterine volume significantly reduced from 180 ml to 86 ml in very many papers, and also in my experience, because we have been using GnRH analogs almost from 2006. So that's an experience of almost 17 years. Adenomyosis has no adverse effects on IVF ICSI outcome in women with endometriosis or adenomyosis, provided they are treated with long-term pituitary downregulation before embryo transfer. This is a very, very significant statement. Adenomyosis causes reproductive dysfunction, but if you treat them with GnRH analog long-term prior to embryo transfer, their success rate is equal to anybody else without adenomyosis. So these are the papers by Niu et al. You can see here with pre-ART GnRH analog, the implantation rate jumped from 16 to 32%, pregnancy rate from 24 to 51%, which is double, and ongoing pregnancy rate also went up from 21 to 48%, which is very important. Though they require slightly longer dosage, higher dosage and longer days of stimulation. And again, there are so many other papers which supported the use of medical treatment, that is GnRH therapy, to improve the pregnancy rates in ART. This is a fantastic paper by Stenokova and Tremelin et al. They use euploid embryos. So the embryo factor is ruled out. They use euploid embryos in the setting of adenomyosis. Without the GnRH analog, the pregnancy rates were less. But after the GnRH analog downregulation, there was a boosting of implantation, and also the post-implantation pregnancy health improved. That means the number of miscarriages decreased. Very important paper. This is one of our patients with the subtle adenomyosis. Unless you really look for it, hunt for it, you may not see it. We gave her she had prior implantation failures elsewhere. We gave her 11.25 GnRH analog suppression. After 6 weeks, you saw barely any change. But after 12 weeks, you can see the mass is almost regressed, except for 2 small cystic areas. This is at 12 weeks. And 16 weeks, we did the embryo transfer. She conceived twins with a good outcome. This is another patient with 4.7 centimeter posterior wall adenomyosis, but with previous laparoscopy elsewhere and previous failed IVF elsewhere. She also had tiny chocolate cysts. And many times in the panel, my colleagues would say, I want to do an adenomyomectomy, especially when you see the 3D. They're all tempted to do an adenomyomectomy because there is a small impinging of the endometrial cavity. This lady, once again, we collected the embryos, vitrified them, gave her a good GnRH suppression for about 16 to 18 weeks. And after the embryo transfer, there was a live birth of a single child, which is very important. So we could avoid the surgery. And also, you are not worried about rupture uterus or adhesions. So a patient with 4.7 centimeter adenomyoma did very well with medical suppression. How good is Dinoges? Dinoges is very good for relief from pelvic pain, but it's not the best for controlling menorrhagia, and it's not ideal for reduction of uterine volume. And this is a paper by Matsushima et al. For 16 weeks. They have used the 3 drugs, GnRH analog, low-dose estrogen progesterone, and Dinoges. With GnRH analog, 300 cc uterine volume came down to 177 cc after 16 weeks. Low-dose estrogen progesterone or Dinoges, there was no change at all. You can see that. So that speaks for the strength of GnRH analog for your infertile patients where you require suppression of adenomyoma and reduction of uterine volume. Aromatase inhibitors are second line of medication. In case of resistant adenomyosis, wherever the GnRH is not really giving you results, you can add aromatase inhibitors. You can use letrozole 2.5 milligram per day or 5 milligram per day. You can also use anastrozole, and you can use it for 8 to 16 weeks. And the combination of aromatase plus GnRH can give a reduction in uterine volume by almost 60%. So there is reduction of adenomyoma volume and also the size of uterine volume. And paper by Scarpellini et al., where the combination of aromatase plus GnRH gave 48% pregnancy rate compared to Dynogest, which gave only a pregnancy rate of 20%. So once again, a very impressive fact. This is one of our own patients with large adenomyosis. This is 7.6 centimeter adenomyosis, 7 into 4.4. Prior pregnancy loss and secondary infertility. She had an AMH of 1.26. And uterus was enlarged about 12 week size. 344 cc is the volume. The normal volume of uterus is 60 to 80 ml. Once again, itching to do a surgery, but we went in for a medical suppression, a medical adenomyomectomy. Her AMH was low, 1.2. So went in for antagonist protocol, collected the eggs, vitrified the embryos. And then this was during the COVID year of 2020. Initial volume was 344 cc. She had 2 doses of 11.25 and 1 dose of 3.75. Suppressed from March to September. And also letrozole 2.5 milligram along with northistrone acetate 5 milligram to reduce the chance of bone mineral density. So with 6 months of suppression, her uterine volume came down to 204 cc, and we did a frozen embryo transfer and we were successful. You can see this adenomyosis with the early pregnancy, still a bit frightening. You can still see the strands of adenomyosis. And at 12 weeks, you can see this is a 11 weeks, 6 days pregnancy and adenomyotic changes. And I was worried about preterm labor. Nothing happened. She went to term and had a term 37 weeks LSCS and a healthy female child of 2.7 kg. This was 2020. And Mirena can also be used. LNG-IUS can be used in some women with thick endometrium. You can use it along with GnRH analog and seems to help in uterine volume reduction and also to combat the problem of endometrial hyperplasia, which you see sometimes with adenomyosis. So once again, a paper by Wong et al., the implantation rate was 32% and clinical pregnancy was 44% compared to the control group, which had much less pregnancy rates. Intrauterine device releasing danazol is being tried in European countries, either intrauterine or vaginal, and seems to give good relief from pain of DIE and suppresses adenomyosis. But it's not available in India. And there are papers from China talking about the impact of uterine volume. According to this paper by Siaku et al. In 2021, the ideal uterine volume seems to be less than 100 ml, but it's not really possible to achieve this much volume reduction. In our patients, the volume came down from 344 cc to 200 cc. And sometimes it reduced by 60%, but 100 ml, though he says, according to this paper, more than 98 ml is not ideal. But in our experience, even with 150, 200 ml, they conceive and they do very well, provided you give a pre-embryo transfer suppression. Can I talk for another 2 minutes? So who will benefit from uterus sparing surgery in adenomyosis? Give them medical management, do a medical adenomyomectomy, not surgical adenomyomectomy. So if they're not responding, if there's a recurrent implantation failure, or if there is severe dysmenorrhea or heavy menstrual bleeding, not responding to medication, that is the only time that you have to go in for uterus sparing surgery in adenomyosis. This is according to the master, that is Osada, in 2018. And because whenever you do adenomyomectomy, it's not like a cakewalk. You have so many adhesions. You have to counteract the adhesions. And then you do not know where exactly to stop. The surgery does not have a capsule like myoma. So the disease can recur very quickly within 3 months. Most of us suppress the disease for 3 to 6 months following adenomyomectomy. Adhesions can reform, recurrence can happen. And once again, there can be chances of ruptured uterus during pregnancy. This is why we have been fighting against the tendency for adenomyomectomy unless there is lack of success by medical adenomyomectomy. These are the various methods. Sun et al. And Osada, once again, he prefers open adenomyomectomy and he sutures it in the form of triple flap. You can see here. Open the uterus completely, put your finger into the endometrial cavity and remove all the adenomyotic tissue and then suture in 3 flaps, reducing the chances of rupture uterus. According to him, the success rate was 55% and rupture uterus was nil. But in a big series from Japan, they saw that there were 6% cases of uterine rupture. This is a paper by Kishi et al. So according to Osada, diffuse cases, large adenomyotic uteri, do open surgery if really needed. Smaller focal adenomyosis, you may not operate at all. If at all you need to operate, do it by laparoscopy. So what is the role of hysteroscopy? In a patient with infertility, I would say there is no role for hysteroscopy. You can do it in women who have menorrhagia once they have completed the family. And this is another patient of ours with the recurrent pregnancy loss. We went in for adenomyomectomy because she was not responding to medical management. And her IVF after adenomyomectomy were successful and she had a full-term twin birth. And this was a uterus cesarean section. We brought it out, so there's little congestion. Otherwise, there is no indentation or additions. And the lady with the posterior wall myoma, she did respond very well to surgery and had a live birth following that. This is a patient with previous adenomyomectomy failure and also previous IVF failure elsewhere, married for 15 years. So recurrent adenomyosis after surgery, we suppressed her with 2 doses of long GnRH agonist. There's 11.5, 2 doses, along with norethindrone acetate. And then we did the embryo transfer. Now she conceived twins, and this was a live birth in March 2007. So women with adenomyosis, when they come to you, screen them for male factor, female factor, treat them like anybody else. Mild adenomyosis, they may conceive naturally or with IUI. If there is no response, you can go in for a couple of cycles of IVF, do embryo transfer after suppression with GnRH analog. With this, mostly you are successful. If there's no success, recurrent implantation failure or recurrent pregnancy loss, you can go in for adenomyomectomy. Uterine artery embolization and HIFU, once again, are under trial. But as we stand today, we favor it for women who have completed the fertility. To conclude, adenomyosis is a challenging condition to treat in the scenario of subfertility. It's interesting to note that with the ART, there was good pregnancy rate and good reproductive outcome in adenomyosis. Well-designed, adequately powered studies are required to study the impact of adenomyosis on management of subfertility. Thank you all.
Thank you, Asha ma'am. That was very crisp and knowledgeable talk. We can have question and answers after we have the all lectures. Now I invite Dr. Brinda Joshi Kale ma'am for her talk on evaluation and medical management of endometriosis. Over to Dr. Brinda Joshi ma'am.
Thank you, Dr. Pratishtha. And it has been a very nice discussion by Dr. Asha. And actually, my deliberation and when compared to Dr. Asha would be like that, talking about a kindergarten kind of thing. But I suppose that for those who have just entered into the field of obstetrics and gynecology, probably the kindergarten knowledge is also very important, because once they apply it to the population of women who come to them, then only they will be able to pick and choose who are the women who need further treatment, as has been so beautifully described by Dr. Asha Rao. Thank you, Dr. Asha, for the presentation. And so my discussion is just about the evaluation and medical management of endometriosis. Next slide. Please change the slide. So this is nothing to be elaborate about, but we know that the diagnosis of endometriosis is difficult and we need high index of suspicion, because there may be a delay of many years between the symptoms and definitive diagnosis. The symptoms are varied, which may vary from mild to severe dysmenorrhea, dyspareunia, chronic pelvic pain, ovulation pain, perimenstrual pain, infertility, sometimes nothing but simply chronic fatigue, or nothing but pain during defecation and micturition. And there are many other very vague symptoms which may be because of endometriosis. Next slide. Next, the diagnosis we know is mainly dependent on the palpable tenderness in the pelvis, a uterus which may be fixed and retroverted. The size may vary depending upon the degree of adenomyosis. Then very commonly found is the posterior fornicial induration, or what we call as tender uterosacral ligaments, or enlarged ovaries, which may suggest endometriosis and chocolate cysts. And of course, the presence of deeply infiltrating endometriosis in the form of nodules in the uterosacral ligament in the pouch of Douglas. Sometimes visible lesions may be there on the vagina and cervix. And rectovaginal examination should never be skipped in order to identify deep infiltrating endometriosis. Next slide. Next slide, please. For a definitive diagnosis of endometriosis, since I am dealing with the evaluation part, visual inspection of the pelvis at laparoscopy is the gold standard investigation, unless the disease is visible in the vagina or elsewhere. Most of the time, we go by the clinical examination and symptoms and then go for laparoscopy to confirm our finding. However, there is insufficient evidence to justify timing the laparoscopy at any specific time of the menstrual cycle. But plan the laparoscopy. It should not be performed during or within 3 months of hormonal treatment so as to avoid underdiagnosis. Next slide. Next slide, please. The role of transvaginal sonography in diagnosing endometriosis, which is more and very widely available. It has become like the third finger of the gynecologist. It still has limited value in diagnosing peritoneal endometriosis, but is a useful tool to exclude and make the diagnosis of ovarian endometrioma, that is chocolate cyst. It may have a role in the diagnosis of disease involving bladder or rectum. The specificity for endometrioma is very good, though the sensitivity may or may not be there. Next slide. Classical appearance on ultrasonography. It is homogeneous hypoechoic mass with low-level internal echoes with hyperechoic foci within the walls, and 95% show internal echoes, and hyperechoic lesions are due to cholesterol deposits. Lesions may be unilocular, multilocular with thick and thin septa. Next slide. The differential diagnosis, next slide, is with a dermoid cyst or hemorrhagic cyst or a neoplastic cyst, which is very difficult, and many a times on opening or on doing laparoscopy, we find the difference and need a good sonologist to make sure of it. Transrectal ultrasound comes to our help because of its better resolution, diagnostic accuracy, and a restricted field of visualization. And it can identify the deposits which are round hypoechoic infiltration of the bowel wall and seen as thickening of the muscularis propria. The sensitivity of transrectal ultrasound is 97%. The specificity is 89%. Next slide, please. Doppler has a diagnostic accuracy which enhances our two-dimension. Pericystic flow with a resistance index of more than 0.45 indicate low resistant waveform. And another helpful tool is using magnetic resonance imaging. The advantage is it images the entire pelvis in multiple planes, and particularly it is useful in evaluating the rectum and the cul-de-sac. The appearance depends upon the iron content, the proteins, and the products of blood degradation, which may be there in and around the endometriotic deposits. Next slide, please. The role of CA125, it's a much used marker, but it has a very low sensitivity, and therefore it is not of any use as a screening method. It can only help to predict recurrence. The levels in non-menstrual phase may vary between minimal to mild and moderate to severe. It may vary. Sorry for the interruption. Then 80% of patients with pelvic pain and raised CA125 levels have endometriosis, while only 6% of those without endometriosis have raised CA125 levels. High levels of CA125 have been reported in cases of large endometrioma or ruptured endometriomas. Next slide, please. Now coming to laparoscopy, which is the gold standard to diagnose the extent and severity of the disease, but it should not be performed within 3 months of hormonal therapy to avoid underdiagnosis. Methodical approach is required. Thoroughly inspect the lateral side walls, all ovarian surfaces, both sides of broad ligament, bladder, bowel, serosa and inferior aspects of the cul-de-sac. Uterine manipulation will help in visualizing the pouch of Douglas and rectovaginal septum, and photography and video recording, which are the mainstay, will help us in recapitulating what all we have seen and in describing, in showing the relatives about the extent and severity of the disease. Next slide. So now coming to the second part, that is what are the treatment options. I am so happy that Dr. Asha has already discussed many of the medical therapy which is now being used commonly, but still as a basket of what all available things are there, starting from the minimal endometriosis to the maximal or the most severe ones. We can use pain relief in the form of NSAIDs and COX-2 inhibitors, use of combined oral contraceptives, use of progestogens, use of antiprogestins, GnRH agonist and antagonist, aromatase inhibitors, and now the things that are being tried are the SERMs and sperms. They are also being tried. And then, of course, there will be a full dialogue about surgical treatment by Dr. Dhaval. So we would be discussing each one of these treatment options in a short summary form. And actually, in our practice, we find that each of the medical therapy option has its own role because it is so patient dependent, and endometriosis per se is so subjective a disease where the complaint and the relief is totally subjective, where it depends upon the person or the woman or the patient who will accept a therapy or will not. So we must be acclaimed or acquainted with all of them. Next slide, please. Next slide. Yes. So NSAIDs are effective in managing endometriosis associated pain. There is inconclusive evidence, but suppression of ovarian function for 6 months, however, reduces endometriosis associated pain. And so all those medical therapies are equally effective, but their adverse effects and cost profiles differ and can be chosen accordingly. Next slide, please. This is the RCOG guideline. Now, ACOG recommends 3 months trial of NSAID and cyclic oral contraceptive pills. If the pain persists after 3 months, then go for laparoscopy. If the patient is more than 18 years and wishes to avoid surgery, we can go for empiric GnRH agonist. And if pain resolves, then diagnosis of endometriosis is confirmed. So that is for the empiric diagnosis by using some suppressive agents. Now, any low-dose oral contraceptive pill containing 30 to 35 milligram of ethinyl estradiol used continuously to achieve amenorrhea can be effective in the treatment of endometriosis. Cyclic OCP is used to provide prophylaxis against either the development or recurrence of endometriosis, and NuvaRing, which can also be used. Next slide, please. Next slide, please. So the various progesterones, they also act actually by reducing the estrogenization and the effect of estrogen receptors. And they are medroxyprogesterone acetate given in the dose of 30 milligram daily in divided doses. Then norethistérone acetate, which is given as 2.5 or 5 milligram daily orally. Megestrol, lanestrol are not in use, but dihydrogesterone, yes, though it's a costly form, but it is very friendly and in the dose of 20 to 30 milligrams daily orally. Next slide, please. GnRH agonist, these cause pseudomenopause by downregulation of the pituitary and are very effective. They are indicated if the patient is unable to have an acceptable degree of pain control with COCs, not to be given if less than 17 years. Leuprolide in the dose of 3.75 milligram per month, or gosserline 3.6 milligram per month, or buserelin, nafarelin, or triptorelin. Add-back therapy should be added to GnRH agonist therapy in the form of conjugated ethinylestradiol 0.625 milligram plus norethindrol alone, or tibolone is also coming away in the form of 2.5 milligram plus 1,200 milligram of calcium and vitamin D daily. This is because the bone resorption and bone demineralization is very evident with GnRH agonist long-term use, and fractures may also occur. And that is why add-back therapy is very important whenever a patient is given GnRH agonist. Effectively treats endometriosis-associated pain while prevents vasomotor symptoms or bone loss. Treatment up to 2 years with COC add-back appears to be effective and safe in terms of pain relief and bone density. GnRH antagonist can also be used, but when coming to the patients, general patients, not taking treatment for infertility or so, agonist will be of much help. Next slide. Next slide, please. Please change the slide. Yes. Now, LNG intrauterine system has already been discussed by Dr. Asha. It appears to reduce endometriosis-associated pain. Insertion after laparoscopic surgery for endometriosis-associated pain. Significant reduction in the risk of recurrent, moderate to severe dysmenorrhea at 1 year follow-up. Causes significant reduction in pain, dysmenorrhea, dyspareunia, and size of rectovaginal endometriosis up to 3 years. And also has minimal systemic effects, effective contraception, and long-term 5 years benefit as compared to 6 months, typical of GnRH agonist treatment. So LNG intrauterine system, as I earlier said, though endometriosis is a very subjectively oriented disease or condition, it depends how the patient takes it and approves the system. But LNG has been found to be very useful in mild to moderate endometriosis as well as in adenomyosis in relieving the pain of that when when infertility or fertility is not the issue. Dynogest, highly selective progesterone receptor modulator, as effective as GnRH analog, may prove better option. Next slide, please. Next slide. So it is a selective progestin that only binds to progesterone receptors and is a unique 4th generation synthetic progestogen. It is recommended by multinational guidelines as the first-line drug for the long-term management of endometriosis. It has a very good tolerance, good anti-androgen activity, moderate inhibition of hypothalamo-pituitary ovarian axis, moderate reduction of estrogen levels, minimal impact on estrogen, sugar, salt, and lipid metabolism. And therefore, today, many a times, Dynogest becomes the first-line drug to be given orally 2 milligram per day for extended duration. The duration for which Dynogest can be given is very varied, and various papers, various publications from all over the world are varying in the duration for which it can be used. When it is used in the form of oral contraceptive pills along with estradiol, long-term usage like that of COCs of many years has also been recommended and found useful in endometriosis. Next slide. Danazol, though it was first drug, now we are not using it anymore. And the concept of a danazol containing IUCD or IUD is really worthy identifying. Gestinone, it causes cellular inactivation and degeneration of endometrial implants, 1.25 to 2.5 milligram twice weekly for 24 weeks. Amenorrhea occurs in 50 to 100% of cases. Equally effective, seems to prove good alternative. It may be androgenic but less intense than danazol, and pregnancy is contraindicated with it. Now, mifepristone, which is now a very widely used drug in various indications. Now, like misoprostol, the indications of mifepristones are increasing day by day, from abortions to induction of labor to induction of abortions and whatnot. So mifepristone in the dose of 25 to 50 milligram per day seems promising also in reducing endometriosis associated pain, and it can also be given for a long time. The one problem or one thing that may be associated with it is a thickening of the endometrium. Next slide, please. Next slide. So thickening of the endometrium, which may result in, when it is stopped, there may be some heavy menstrual bleeding following stopping of the mifepristone tablet. That needs to be taken care of, though it never leads to hyperplasia of significance, that is no malignancy detected. Now, the role of aromatase inhibitors, it's the key enzyme. Aromatase is the key enzyme responsible for estrogen production in the ectopic endometrium, and it is further stimulated by PGE2. Now, inhibitors decrease local estrogen synthesis, that is aromatase inhibitors, and inhibit the growth of endometriotic implants. But they also require add-back therapy to protect bones. Letrozole, that is 2.5 milligram, along with norethistérone and calcium, can be given for 6 months, causes reduced pelvic pain scores and no significant change in bone mineral density. It is another promising alternative therapy, alternative treatment in the cases of painful endometriosis. Next slide, please. Mifepristone, we have already discussed about the progesterone-associated endometrial changes. Next slide, please. Then about SERMs, non-steroidal anti-estrogens which bind to endometrial receptors. Estrogen receptors can act as either estrogen agonist or antagonist depending on the target tissue. They have estrogen antagonistic activity on the endometrium but agonist activity on the bone. Their role is yet to be studied, though not many studies have occurred after this slide has been formed. Then raloxifene, which decreases the volume of implants in dose-dependent manner. Next slide, please. Selective progesterone receptor modulators, they are also being tried. Next slide, please. Next slide, please. So there has been earlier with Dr. Ashara, we have had a good discussion about infertility and endometriosis and adenomyosis. Suppression of ovarian function to improve fertility in minimal and mild endometriosis is not effective and should not be offered for this indication alone. There is no indication of evidence of its effectiveness in more severe disease. Post-operative hormonal treatment has no beneficial effect on pregnancy rates after birth. That is level 1 RCOG guideline. Next slide, please. Next slide, please. Ablation of endometriotic lesions plus adhesiolysis may be effective. Role of surgery in improving pregnancy rates for moderate to severe disease. No randomized, now though there are so many randomized control trials now available. Next slide, please. Now, recurrent endometriosis, spontaneous resolution occurs in about 20% endometriosis stage 1 and 2. But residual disease or persistence of symptoms or reappearance of symptoms within 3 months will be considered as residual disease, and recurrence that which appears after 3 months. Now, incidence is 6 to 30% in various studies, depends on the age, the stage of the disease, prior treatment, completeness of surgery, extent of peritoneal disease, and usually presents as chronic pelvic pain and dysmenorrhea. So in this aspect, recurrent endometriosis is as problematic as ovarian malignancy, where we have to do rather total wiping away of the like ovarian malignancy. So endometriotic implants, even a few of them which remain after the surgical treatment, may result further in pain and recurrence of the endometriosis. Next slide, please. Next slide, please. Diagnosis is rising CA-125 by transvaginal sonography, by MRI, by laparoscopy. Treatment again would be simply pain management, same thing again, hormones like progesterone, OCP, GnRH, conservative surgery indicated if medical therapy fails or contraindicated. Cystectomy, adhesiolysis may again be done. Post-operative hormone therapy delays recurrence but does not reduce the recurrence. So LNG-IOCD reduces recurrence post-surgery and role is being studied in recurrent disease. Hysterectomy with bilateral salpingo-oophorectomy also, of course, remains a further choice, but it may not be of use in cases where there is deep infiltrating endometriosis in bowel and bladder. So this has to be clear to any endometriosis or adenomyosis patient who comes to us begging for hysterectomy so that she will be relieved of the pain, that this needs to be cleared right in beforehand, that deep infiltrating needs to be treated separately, and it's actually a big surgery. Next slide, please. So the last slide of my talk, treatment must be individualized. That is very, very important. Multidisciplinary approach involving pain clinic and counseling should be considered because this is a very subjectively oriented disease. It is an inflammatory and estrogen dependent condition, endometriosis. Drug targeting this are under trial. Laparoscopy is the gold standard diagnostic tool. Drug therapy should be selected considering efficacy, cost, and adverse effects, and of course, the patient's preference. Treat early and aggressively by surgical destruction or excision, preferably by laparoscopy. Thank you so much for a patient listening. Thank you all.
Thank you, Dr. Vrinda Joshi, ma'am. It was a very concise talk, very knowledgeable. Now we move on to our third speaker, Dr. Dhaval Bakshi. I hope he is joined now. He'll be talking on fertility enhancing surgeries in endometriosis. Over to Dr. Dhaval Bakshi.
Very good evening to everyone. Just landed in Raipur, so I've just managed to log into my system. First of all, I'd like to thank everyone from the Gwalior Obs-Gynae Society, Pam Madam, Rosa Ma'am, Anju Ma'am, Yatindra Sir for inviting me to be a part of this webinar also. Yatindra Sir once again because he's the chairperson of MPSR, and Nandita Ma'am who's the chairperson of ISAR, the president of ISAR. So since I was at the airport, I've already pre-recorded my talk, and I'm just going to share that screen because here delivering a talk is a little bit difficult. So I'm just sharing my pre-recorded talk, which is just going to be a video. And then after that, I can come back for the discussion. So just sharing the screen now.
Dhaval, you're muted. I think your voice is not being heard.
Ma'am, is it heard now?
Yeah.
Yeah.
Still, we are not able to listen you, Dr. Dhaval.
Oh, okay. You can't hear the video, the audio from the video?
Video is the...
Oh, okay. Acha, wait. Share screen. There, but... Okay, one second. Okay. I'll stop the sharing now. And then, where do I go now? Oh, okay. Yeah. Found that. Doing that. Okay. Yeah. Just let me check now. Okay. Mechanical interference with the side pickup and transportation. There is anatomical dysfunction of the fallopian tube and the ovarian anatomy. and there is an exposure to hostile environment of macrophages, cytokines, and vasoactive substances in the peritoneal fluid, which are which hamper the ability of the oocyte or the developed embryo to go ahead and get implanted. Endometriosis also impacts the ovarian reserve, and it can happen by entering its circulation in the ovarian cortex by the compression, the mechanical compression due to the cyst, and therefore causing follicular loss, or the inflammatory setting within the cyst walls, which leads to follicular damage. So this is how the ovarian reserve reduces. So regardless whether you do surgery or you don't do surgery, the impact the reserve is going to get reduced. So some form of the other has to be taken, and there is no role for just observation in cases of patients with endometriosis. So a lot of people think that if there is endometriosis, why do you want to do surgery? Just go ahead and do an IVF. So there is a lot of data which is available from the START database. And so they've analyzed around 3.5 lakh cycles in women with endometriosis, and they've seen that it is associated with the lower oocyte yield, lower implantation rate, and lower pregnancy rates after IVF. So, and also when there are coexisting other problems, like if she has fibroids, if she has Mullerian abnormalities, if she has something else, so then that will have the lowest chance of a live birth. So what is the role of surgery? So first and foremost, establishing a diagnosis, although this is quite controversial, and now the new ASHRI guideline says that don't do a surgery just to establish the diagnosis. You can confirm the diagnosis, but the diagnosis has to be made in your OPD itself. Definitely for staging of the disease. So this is the diagnostic part, and then you go for the corrective part, which is the restoration of the anatomy, treatment or excision of the diseased tissue, and preservation of the function of pelvic organs, especially in when you're dealing with patients with infertility. And our sole aim is to enhance the fertility. We want to also simultaneously be able to reduce the patient's pain, but fertility enhancement has to be our primary goal. So how do you stage the disease? The ASRM staging is quite popular, which classifies the disease into mild, minimal, mild, moderate, and severe disease based upon the findings, and it is quite popular. The NGN classification has also come in with all the advent of all this deep endometriosis. So it gives the specific sites of the deep endometriosis, and this correlates quite well. There is a paper by Dr. Vimi Bindra in which she has correlated the ultrasound findings as well as the surgical findings as per the NGN classification, and it correlates quite well. So this allows you to help in more accurate documentation of the disease. When it comes to fertility per se, the most important tool is the endometriosis fertility index, which is basically a combination of historical factors as well as surgical factors. So here there is so in the historical factors, there is a particular score. Then the surgical factors include a least function score as well as the SRM score. And depending upon that, you get an estimated percentage pregnancy depending on the EFI score. So the higher the score is, there is a higher chance for the patient to conceive spontaneously on their own. If there is a very low score, so it is more apt that the patient should go ahead and undergo ART. So this acts as a very good triage tool in cases of infertility. So now coming to the disease. So first of all, we need to see how to tackle superficial disease. So there are two ways to do it. You can either ablate the lesions just with your bipolar, or you can go ahead and excise the lesions. No matter what you want to do, you want to always have a look at where the lesions are, where the ureter is, and go ahead and treat them. Depending upon when it comes to fertility outcomes, ablation versus excision does not have any difference in the surgical outcomes of the disease. However, when you excise the tissue, there is a lower chance of recurrence, and in patients who also have pain, the pain scores also go down. So going ahead, when the disease is a little bit more severe, when we're looking for restoration of anatomy, So here you can see that this patient has bilateral endometriomas. He has an obliterated pouch of Douglas. There are a lot of tubo-ovarian adhesions, and the whole anatomy is distorted. So here what we've done is we're going ahead and restoring the anatomy. So this is quite a relatively delicate surgery. I would say fertility enhancing surgeries for endometriosis are one of the most difficult surgeries, even more difficult than doing oncological procedures, because here you're dealing with a lot of inflamed tissues and you have to preserve the organs at the same time. So here now we're going ahead, and once all the anatomical restoration has been done, we're going ahead and performing the cystectomy. I like to divide the cyst wall into two parts and then excise it. This allows excision of the endometrioma with very little loss of the ovarian tissue. We don't put in any vasopressin and go ahead and complete the cystectomy. There is very minimal blood loss and very minimal oozing. So basically, the maximum loss to the ovarian reserve occurs when you apply a lot of cautery for hemostasis. So that is not done. Here now what we're doing is we're developing the medial pararectal space. So the first step includes identification of the ureter. Once the ureter is identified, we then go ahead and try to identify the inferior hypogastric nerve. Once the nerve is identified, we have to go medial to it and hug the rectum while we develop the space. Here, the structure that you just saw was the inferior hypogastric nerve, and we're going medial to it and just dissecting the pararectal space and opening up the Okabayashi space. Here, once again, we confirm where the ureter is, and you can see that we're quite medial to the ureter. So fat will always belong to the bowel and the bladder. So you have to always use that as a landmark to go in ahead. The aim is to get to both sides of the adhesions and develop windows on either side. These guide you on how to go ahead with your further central dissection. Here you can see me using the harmonic scalpel. The harmonic scalpel can be used quite easily when there is fat, because there is very minimal lateral thermal spread, and chances of thermal burns are quite low. Once you go down and you feel that you're close to the serosa, you can just switch over to cold scissors and keep on dissecting. You will usually be cutting through the nodule, which is going to be a tough structure. And at one point of time, you will open up into this clear space of areolar tissue, which will be the Denon-Villiers fascia. So you just go ahead and follow those lines and develop the new cul-de-sac or the new pouch of Douglas. So here you can see that we've done that quite well, and we're just going inside and dissecting it further. So here many a times one wonders that why not, how do we know how far do we have to go and what are the landmarks. So in the pouch of Douglas, so you will always see the posterior wall of the vagina and the reflection of the manipulator on it. Use of interseed is controversial. Some of us use it, some of us don't, but I in my practice am using it quite regularly. So ovarian endometriosis, once again, I think we've covered it quite a lot. I'll just go ahead and jump directly to the cystectomy part. Here you can see that I'm dividing the cyst in the middle, and just with scissors, I'm teasing off the cyst. So why do I go through the middle? Because the middle is usually the most avascular area and where the plane is well developed, and there is very less adhesions and very minimal fibrosis in the central part. So that is why once you've developed this and you've gotten into the right plane, then after that you just go ahead and strip off the ovary from either side. And here, without using any vasopressin, without using any diathermy, we are able to complete the cystectomy and this way minimizes the loss of normal ovarian tissue. So a lot of people also use vasopressin to reduce to reduce the amount of bleeding during these surgeries. But I personally don't like to use vasopressin. Vasopressin, in theory, will reduce the amount of oozers and therefore reduce the amount of time that you have to use the diathermy. But I personally like to go ahead and just use the normal technique, because sometimes you can inject the vasopressin into the wrong plane, and once that happens, then you might end up stripping off more normal tissue than what is needed. So the effect of surgery on spontaneous pregnancy rates is quite promising. However, sometimes it might reduce your IVF outcomes, and sometimes the ovarian reserve diminishing reduction that occurs due to surgery is worse than what would be there, the same AMH level, but there will be a poorer response to stimulation had it been an idiopathic reduced ovarian reserve. So basically, the current indication for surgery before IVF is only if the ovaries are inaccessible due to adhesion, if the endometrium was anticipated to be in the path of the needle during oocyte retrieval, if there's anticipated difficulty in embryo transfer due to position of the uterus, or if there are recurrent IVF failures. So our strategy is usually in patients with severe endometriosis to like to retrieve the oocytes, perform the surgery for endometriosis, and then go ahead with the embryo transfer. So to conclude, endometriosis is one of the most bewildering, debilitating, and chronic conditions with increased incidence of infertility, and diminished and further declining ovarian reserve is a very big challenge in getting good results. Surgery should aim at preservation or enhancement of reproductive function, and primary surgery gives the best chance at improving fertility outcomes. And the role of surgery before IVF is still not clear. So once again, to reiterate, you need a multidisciplinary team of an obstetrician, of a gynecologist, endoscopic surgeon, and a fertility specialist, an ART specialist, to tackle this conundrum and this threat of endometriosis in infertile patients. Thank you very much. Yep. So thank you very much for the lecture.
Thank you so much, Dr. Dhaval. You took so much pain while traveling, even to attend and prepare this webinar, this talk. Thank you so much. It was really an enlightening talk. Now, I invite our chairperson, Dr. Rosa Oliai, ma'am, for her closing remarks and discussion on the topics. Rosa Oliai, ma'am.
Yes, thank you, Pratishtha. And also, thank you for the kind words that you have.
I think Dr. Archana Baser has left.
Yeah.
Baser is there?
No, I'm not able. She has left.
Yes. So please, Rosa, please continue.
Okay. Well, at the outset, let me congratulate Dr. Yatin Verma, who's the chairperson of SRMC. Really so proud to have my classmate as a chairperson. And of course, Dr. Monica Jain, who's the secretary. Other friends, Dr. Anju has been the convener and in touch with me all the time. And of course, Pratishtha, who's the MOC and quite active in all the infertility work here. It's really nice to have Mangla also. I can see her here and other ISAR members. And of course, my very own dogs, my dear Dr. Palm and Preeti, who's here from GOGS. Vranda spoke so beautifully, Dr. Vranda Joshi, about the management, the initial treatment, and so very well she elaborated the medical management. And I do agree with Dhaval when he mentioned that the endometriotic guidelines development group in 2022 have talked about more of symptomatological treatment rather than doing a laparoscopy. So it's going to be a gynec kind of diagnosis in the clinic. I was just going through the guidelines. So I thought it's so important for us to use ultrasonography and especially TVS and MRI. Dr. Asha Rao very well mentioned about the role of ultrasonography and MRI in detail. And I think that goes a long way for us, those of us who are doing ultrasonography, to see the uterus, to see the lining, and when to do the surgery, when not to do the surgery. Further on, the American Society Reproductive, I was just going through some of the journals, mentioned about using, if you have someone like Dhaval with you in your city, you go ahead and do endoscopic surgery. But for those of us It's no use of just doing a diagnostic laparoscopy. It needs to have an expert hand to get the surgery done, which is so very important. Because so many, surgeries done at the end of it, you see, is going to cause depression for the patient. How studies have shown that about 70% of these endometriotic patients are with anxiety and depression. I think it's time for all of us. I would like to suggest for Dr. Asha Rao, since she is the chairperson of the committee, to develop a support group with the patients who can get together. We have this with the Royal College guidelines where we do it often, but in India, it's still time for us to start with a support group, because pain associated, whether you are for infertility or not having that, it's add-on issues. So I think it's very important and high time for us to come. Dhaval, your demonstration, your surgical hand, absolutely good. It's like drinking, water when we see the videos. I know you're doing great work. Keep up the good work that you're doing. And of course, as I mentioned again, it's important to do this laparoscopic surgery with expert hands and not just start doing it for diagnostic purposes. So my best wishes for the ISAR MP, all of you all, the team together, to go ahead with doing more and more important topics. Just one little touch on adolescent endometriosis. I know it's about infertility, but most often we've come across those girls whom we are treating. They've got non-cyclic pains and they are not really with, painkillers. We should think about structural anomalies, Mullerian anomalies in these girls. Maybe we can then in these cases do a diagnostic laparoscopy. So that was just, take-home message, because we've come across a lot of increasing number of young girls with endometriotic pains. So my best wishes to all of you. Thank you so much. Over to you. Yeah.
Thank you so much, Rosa ma'am. Now we move on to Dr. Monica Singh for question answer sessions. Dr. Monica Singh, as we all know, is an associate professor with LN Medical College, Bhopal, and she is a secretary MP chapter ISAR. She is also vice president, Bhopal Obs and Gynae Society. She is the member of Foxy Infertility Committee, and she has achieved many awards and many poster and oral presentations in ASHRAE and Ashram and Aspire. We know her all very well. Over to you, Dr. Monica Singh, ma'am, for the question and answer sessions.
I'm sorry to interrupt. 1 second. I think Asha Rao madam had something to say, and she wanted to say something and to give a few words. Sorry, ma'am. Just
Yes, continue. Yeah.
Nothing much. Sorry, ma'am. Sorry, I interrupted.
No, just to reciprocate to Dr. Rosa's. Thank you, Dr. Rosa, for those lovely remarks. And it's very nice that you came out about the support group. I think it's very important suggestion and maybe we should do it. Just now this month, we did a lot of activity with the endometriosis awareness and a lot of small meetings, talking to patients. And we also have a walkathon and we have competitions going on. But what you said is very right. It's nice to have a support group. Thank you.
Thank you. Wish you all the best. I know you'll do it.
Thank you.
Good evening, everyone. And thank you to all the speakers. Thank you to dear Asha Rao ma'am and dear Dhaval and respected Vrinda ma'am. And it was lovely listening to all of you in the last 1.5 hours. There are no questions in the chat box, but I have a question. I have a few questions to all the speakers. Number one question, especially to Asha Rao ma'am, a patient who is taking Dynogest, ma'am, because she has got a very painful sort of adenomyosis, and she is been on Dynogest for about 1.5 years, and now she wants to go for a pregnancy. So, what will be the washout period for Dynogest after 18 months of continuous therapy? And should we be giving her some fertility medication, or would there be a sort of rebound ovulation in that case, ma'am?
But I think there are some more questions in that question of yours. I should ask, what is the age of the patient? What is the ovarian reserve?
Yes, ma'am.
What is the male factor like? Everything has an impact on the fertility of the woman. What is the size of the adenomyoma? What's the uterine wall?
I'll tell you because she's my patient only. She's 35. AMH is 1.8. She has got one child. about 8 years old, conceived normally, delivered normally. Then subsequently the adenomyoma grew, and AFC is
What is the
about,
size of the uterus now and the size of adenomyoma?
ma'am, the size of the uterus is about 9 centimeter in length, 5 centimeter in width, and AP is also 5 centimeter. And adenomyoma classically is posterior. Anterior also, it's a diffuse adenomyosis, but posterior it is more prominent. And this lady suddenly decided for a second child, and now she's been on Dynages for so long.
What is the ovary like?
Ovaries are AFC, both the ovaries about 3 to 4 antral follicles. So a total antral follicle count is about 7 to 8. She's keen to conceive, but now the junctional zone is very much disturbed. I do a 3D, 4D myself. So now the junctional zone has got distorted and I can't see the demarcation very well. And obviously, ma'am, the vascularity also will be disturbed now. So after Dynagist, what should I suggest her? Should I be
What is her endometrium like? Endometrial thickness?
Endometrial thickness doesn't...
Before you suppressed her?
Ma'am, about 8 mm, 8 to 9 mm, average,
not bad.
2.5 days bleeding, regular cycles. The main complaint she came was, dysmenorrhea, severe cramping pain. So we put her on Dynagist, and then she suddenly said, I want to stop it and I'm going to, I want a baby.
And she's 34, 35 years.
She's 35.
Yeah, her ovarian reserve is sort of guarded. It's 1.8, 1.7. And she has got less number of oocytes. So you can give a wash-off period of about a month.
Okay,
preferably.
Yes.
And then you do an antagonist protocol, collect the embryos, freeze them, and then you suppress her again. I would perhaps suppress her with at least 11.25.
Okay.
JNRH analog. And you tell her, it's very important to counsel the patient. What is her prognosis? With the diffuse adenomyosis, sometimes the prognosis could be guarded. But in our own study of about 80 patients, we had an implantation rate, pregnancies in about 40% of patients, and live birth in about 65% of patients, which is very good, actually.
Yes, ma'am.
In fact, that paper is just ready for submitting to a journal. So do the antagonist protocol, vitrify the embryos, and then suppress her for about 3 months, at least. And then you say that I'll do a trial cycle now, give her Proguanova, see how the endometrium, and if necessary, you can always do a hysteroscopy before transfer in between and see how the endometrium goes. If you can reach an endometrium of 7 to 8 millimeters and with a volume of about 2 to 3 cc, you can definitely transfer.
Yes, ma'am.
Embryos. And we have seen pregnancies in about 40% of patients.
Ma'am, any particular reason for using 11.25 instead of 3.75 monthly? Like you prefer the...
because it's one shot, You do not have to wait for the patient's decisions. I couldn't come. They come 1 month late. I had a wedding of the sister-in-law. They skip the treatment sometimes. I'm very happy with 11.25. I have not seen any problems.
Yes, ma'am. So, you've given us a good way forward because I was using less of 11.25. Now, probably I'll keep 11.25 also with me.
Yeah, I found that leuprolide of Sun Pharma is very good.
Yes.
No problems at all. So, for some reason, depends on how many straws she will get, how many embryos she will get. You can always tell the patient that, okay, first, if you have 4 embryos and they are in 2 sets, you can always tell her that if the first set doesn't succeed, I will suppress you for another 2 or 3 months and then do the second transfer. And maybe you are successful.
Thank you. Thank you so much, ma'am. Dhaval, one quick question for you. Again, like adenomyomectomy, do you do adenomyomectomy for those, big, bulky adenomyomas? And what sort of technique? What is that H-shaped incision? Do you do a wedge sort of resection? How do you stitch? And how is the repair of the uterine muscle after that? Later, when you put a scope, do you find adhesions? And how well does it hold throughout gestation?
So, ma'am, the first answer is the most easy one. That when do you do an adenomyomectomy? So I think So we do an adenomyomectomy when nothing else works. So adenomyomectomy is going to be absolutely the last resort when nothing works. None of your GnRH analog is working, nothing is working. When you have a nice localized adenomyoma, that is only when we'll go ahead and, do an adenomyomectomy. Because the problem with adenomyomectomy versus a myomectomy is that in a myomectomy, you're removing abnormal tissue, which is not a part of the uterine wall and the musculature. So because the myometrium is just displaced there. But here in an adenomyomectomy, you have to actually remove the myometrium, which has been infiltrated into. So in a way, you're weakening the uterine wall. Secondly, there are a lot of, there is a very high chance of opening up of the endometrial cavity during an adenomyomectomy. So then these patients, we've had a lot of patients who underwent adenomyomectomies at our center, at other centers also. And they've come with very severe intrauterine adhesions. So then they have to undergo a second look hysteroscopy to see how the cavity is, and we have to take care of those adhesions, etc., etc., etc. So that is there. Coming to the technique. So the technique, it all depends on the size of the adenomyoma and the location. But what I like to prefer to do is, I like to make a longitudinal incision, a vertical incision, and then just scoop out the adenomyoma from between the serosa and the endometrium. So in that myometrial layer, so I'll try to scoop out the adenomyoma without having to sacrifice the serosa. So because the thing is, if you remove the serosa, so then suturing is going to be a big nightmare. So you want to have this loose, supple serosa, which will come together to get approximated. Otherwise, many a times when you end up removing adenomyoma, so the moment you make an incision, because the elasticity of the tissue is not there, so then even if you just make an incision and you try to repair it, it is going to be very difficult. So that is why you have to scoop out all of that tissue from the middle. And while doing this technique, you have to be very careful of where the endometrium is. So a pre-operative ultrasound done by yourself or an MRI with the picture displayed in the OT, which gives you an exact estimate of how far the adenomyoma is from the endometrial cavity, helps you in planning that. Now coming to suturing. So now small incisions, smaller adenomyomas, you can just approximate them together like you would approximate a myoma after a myomectomy, the serosa after a myomectomy. But in the really large ones, sometimes you like to overlay the flaps one over the other. So this helps in a good reinforcement of the posterior wall. And and usually if you suture them well, I tend to use barb suture for all of these repairs, and they hold up quite well. What I like to do is I like to repair it. After that, again, give them GnRH analog for 3 months, and then wait for a good 3 months. And only after that, then we go ahead and, go ahead with the embryo transfer or whatever the next line of management is.
Thank you. Thank you so much, Dhaval. That was very elaborate. Nice. Any other questions our faculty wants to ask the speakers and all the people attending?
Dr. Shashibala Bhosle, ma'am, if you want to ask any question, Dr. Preeti Gupta.
Hey, Pratishtha.
Hi. If you have any question for the speakers, you can please carry on.
Ma'am, I have one more question.
एक question था वो already है ना मोनिका ने बोल दिया that I am having question. Now it is cleared.
Ma'am, एक और question.
It was very informative actually, and you got all our answers. You got such terrific, prolific speakers. So nothing. And chairpersons, Rosa was there, so she cleared all her doubts, and I think it was lovely. Yeah, and Dhaval's thing I posted in my group also. Join fast. Everything terrific. And endometriosis t-shirt. I liked Madam's idea, Asha ma'am's. That yellow t-shirt. Is she sending us?
Thank you. We are having a walkathon on Sunday.
Okay, ma'am.
We have about 1,000 people. We have 1,200 registered for the walkathon. That's how we release the t-shirt. Ma'am, one more question is there for Asha. Suppose there is an endometriosis patient who conceives and delivers one child, and then she wants spacing also, and she doesn't want her adenomyoma also. Then can we insert an NHUS and then like remove it after 5 years? So what will be the fertility chances after removing LNG for her to have either a natural conception or ovulation induction or other ART?
LNG is the ideal for a woman with adenomyosis. And you can keep it for 3 years, 4 years, whatever she wants. And when you remove it, the fertility returns like anybody else. But there are some patients, in spite of LNGIUS, the adenomyosis can grow. Okay. And in such patients, do give GnRH in between. And you can always remove the LNGIUS and fertility is no problem at all.
अभी ऑपरेशन को 1.5 महीना 8 तारीख की लेडी थी अभी क्या रशीदी प्लीज म्यूट
There are cross talks going on.
Yeah.
Thank you, Asha ma'am. Asha ma'am is a treasure of knowledge. All clinical ultrasound, such a great speaker.
We have a sonologist. Good, you know, and she's very good in ultrasound for endometriosis, adenomyosis, and uterine volume studies. So that's how we grew stronger because of a good ultrasound support. And my husband is a laparoscopic surgeon. My son is a laparoscopic surgeon. So I think together we have been tackling adenomyosis right from 2006. So
you have a fantastic team at home.
Thank you.
Hello, Dr. Monica. I won't just ask question when Dr. Asha. Madam, what is your experience using letrozole? Personal using letrozole in adenomyosis.
Yeah, in fact, I showed you one case. I showed you one clipping today. Yeah, we have used it in about 10 patients where it was a resistant adenomyosis, and out of these patients have conceived. And earlier she had implantation failure elsewhere. When she came to us, we saw that she had a diffuse adenomyosis, posterior wall, 7 into 4.4 centimeter. So instead of going for surgery, we suppressed her with GnRH analog, 11.252 doses, and letrozole, 5 milligram per day.
For how many days?
For how long, ma'am, you continued letrozole?
She got letrozole for 18 weeks. And she got GnRH analog for 24 weeks.
Okay.
Ma'am, only letrozole or with that GnRH
analog? Acetate for 24 weeks.
Ma'am, only letrozole or with the GnRH analogs? Along with
combination.
GnRH.
Combination.
Okay. So letrozole will continue for the 24 weeks.
GnRH for 24 weeks. See, that's the first time we gave her, that was our early experience. So we gave her GnRH depot for one depot. With that, we gave her 8 weeks of letrozole.
Okay.
And this was during the COVID year. Follow-up also was not easy, you know. Then she came back, then we did an ultrasound. We said, no, I want further regression. So we gave her another GnRH analog and another 8 weeks of letrozole.
Okay.
Because we wanted to see how the patient tolerates, what are her symptoms. But she did well. And there was a progressive reduction of the volume. And with a good suppression, then we gave her another 3.7 GnRH analog. And under the cover of that last GnRH analog, we did the embryo transfer. And she conceived singleton and did very well. And there was no preterm labor because according to so many papers, the implantation is good in these women. But what causes problem is the preterm labor.
Okay.
Very sad, you know, in my early days when we did transfer without suppression to lose babies at about 20 weeks, 22 weeks. very sad because they are alive, they are twitching, you can see the sex, and it's sad to lose them at 22 weeks. And this sort of thing did not happen when we started a strong suppression without fear. You give them add-back therapy with norethistone 5 milligram and they do very well.
So you mean to say, ma'am, this adenomyosis leads to myometrial contractility in midterm?
Yes, yes. That's why this I showed you the Hashimoto's paper.
Okay.
The chronic inflammation in the uterine, there is irritability of the junctional zone and also of the myometrium.
So anyway,
quieten the myometrium and the junctional zone before transfer.
Okay, thank you.
We were taught that endometriosis causes every aspect, ma'am.
So that's why I said the problems that earlier were attributed to endometriosis were perhaps because of adenomyosis. And those days, ultrasound was not good enough for detecting adenomyosis.
We are just going to finish our time. So,
yeah, okay.
We are short of time.
Yeah.
I will now request Dr. Asha Bakshi ma'am to give her expert comments and take any take-home message if she has. Dr. Asha Bakshi ma'am, please.
I think that she leave.
She'll leave.
She has left, I think. Okay, doesn't matter. Now we'll
Is there
invite
any
Dr.
role of lifestyle modification and diet in endometriosis patient?
Lifestyle modification is more of exercise. We still do not know what type of diet really. When we were in Abu Dhabi,
kind of anti-inflammatory diets may help in reducing the pain.
Not really. We had a talk on diet in adenomyosis in the SUD conference last week. And ultimately, inference was that diet did not make too much difference.
Okay.
But exercise may help you to stabilize the estrogens and reduce the additions.
And ma'am, I'd also like to contribute that exercise does wonders in managing the pain. So many of these women, they're resting when they have their periods because they have a lot of pain. But when they do when they do heavy exercise, there is a lot of endorphin secretion. And those endorphins are endogenous opioids, which do wonders in suppression of the pain. So a lot of my patients who are still yet to be operated or who are postponing, and we haven't put them on drug therapy, or the ones who are trying to conceive. So they are doing really well when it comes to pain relief when they exercise on the days when they have dysmenorrhea. So the reduction in dysmenorrhea is drastic with weight-bearing exercises, especially not with just yoga or stretching, but it has to be weight-bearing exercises.
That's how you promote them into daily walks, exercise, and walkathon. And this year, July 29th and 30th, we are conducting a International Congress on Endometriosis at Coimbatore, July 29th and 30th. Please mark the dates in your diary. And all of you, please do come, be a part of the faculty, and make it a successful Congress.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Okay, so we have less of a time left now. I invite Dr. Mangla Kawade ma'am for vote of thanks.
I think she is not here. So
you continue, Dr. Anjuman.
Yes.
We can thank each other and say have a good day.
Just formal, I want to thank you,
That's the best way,
Dr. Asha Bakshi madam, for joining and for expert comment. She is leaving early, so we couldn't hear her expert. Thanks for joining. And thanks to our guest speaker, Dr. Asha Roy, Dr. Vanda Joshi, and Dr. Dhaval Bakshi for joining and sparing time and delivering very nice lecture. Thanks to our chairperson, Dr. Archana Base, Dr. Rosa Oliai, for sparing time and joining us for this webinar. Thanks to our GOGS president, Dr. Shashi Bala Bhosle, and Dr. Preeti Gupta, secretary, for being here. And thanks to our MP chapter secretary, Dr. Monica Singh, for very enthusiastic and very elaborative question answer session. And thanks to Emcure people, Rajeshwari, Neha, and Rajiv, for organizing this webinar. So last, I thank our MOC of Dr. Pratishtha for nicely conducting this webinar. Thank you, everybody.
Thank you so much. Thank you.
Thank you all. It was a lovely seminar and I've enjoyed the session.
आप सभी को नवरात्रों की और नए संवत्सर के लिए बहुत बहुत शुभकामनाएं.
Thank you, sir.
Happy
Thank you, sir.
Navratri.
Thank you.
Thank you, everyone. It was a lovely evening. Bye-bye.
Good night.
Bye.
Bye.
Okay.
Bye. Thank